Hello, and welcome to the University of Alberta Child and Adolescent Psychiatry Grand Rounds. I'm Dr. Alice Liang, and I am your moderator today. We are very grateful to be partnered with the FOMD Office of Lifelong Learning, aka L3, to bring you these rounds. I'd like to provide the territorial acknowledgement. The University of Alberta, its buildings, labs, and research stations are primarily located on the territory of the Nehiyah, Cree, Nisitapi, or Blackfoot, Métis, Nakota, or Stoney, Dene, Haudenosaunee, or Iroquois, and Anishinaabe, or Ojibwe of Saulteaux lands that are now known as part of Treaty 6, 7, and 8 and homeland of the Métis. The University of Alberta respects the sovereignty, lands, histories, languages, knowledge systems, and cultures of all First Nations, Métis, and Inuit nations. So just a reminder to use the chat feature if you have a query about technical issues, and to use the Q&A feature if you have a question for the speaker. And you can upvote the questions if you'd like. And just I think as a reminder as well, we do have more interactivity as well. So if you raise up your hand during the Q&A, then we can go to you and you can also verbally ask your question. So I'm very pleased to be introducing our speaker today, Dr. Scott Antoine, who completed his undergraduate training at the University of Scranton in Scranton, Pennsylvania, after which he completed his doctorate at the Philadelphia College of Osteopathic Medicine. He completed an emergency medicine residency and an emergency services fellowship at the Albert Einstein Medical Center in Philadelphia, then served 7 years of active duty with the United States Army as an emergency physician, subsequently moving to Indianapolis in 2005 after his term of service. And he worked as an emergency physician at the St. Francis Hospital until 2019. In addition to board certification in emergency medicine, he obtained board certification in integrative medicine through the American Board of Integrative Medicine in 2016. He also has personal experience with our topic today with his daughter developing pediatric acute neuropsychiatric syndrome, or PANS, in 2013. He and his wife, Ellen, who also is an emergency medicine physician, integrative medicine physician, rather, were able to address the immune response, treat the infection and toxins responsible, and bring their daughter to full recovery. And I guess it sounds like you found your specialty after that. So since then, Dr. Antoine has refined his process and helped hundreds of children recover from PANDAS. And in 2019, he successfully lobbied the Indiana legislature and helped pass a law which prohibits insurance companies in Indiana from denying coverage for medical care, including IVIG, for children with PANDAS. Dr. Antoine wrote a book for physicians on the management of PANDAS, which defined the standard of care in this illness. And it was released in 2024, and you can definitely find it on Amazon. It's a bestseller. And Dr. Antoine also kindly has provided an extensive reference list for this talk. And he is willing to provide a copy of his slides as well, if requested. So yes, we are very delighted and interested in hearing what you have to present today.
So I have a daughter. Her name is Emma, and when she was about 12, she came to my wife and I one day, and she said, um, "I don't think I'm a good person. I don't think God likes me." Soon after that, she began washing her hands excessively until they cracked. She lost the ability to sleep at night, was banging down doors and screaming. She was once a really good student and just her grades tanked. She also was a really compliant, sweet kid and just became absolutely rage-filled and aggressive. So when this happened, we weren't sure what was going on. And so we called the pediatrician, didn't get a whole lot of answers there. And so we hit the books. My wife, Ellen, is also a physician. And so we looked and looked. And one day, a few days later, she came to me at about 10 o'clock at night with an article from the peer-reviewed medical literature on PANDAS. And I looked at it, I didn't know what that was, took one look at it and said, oh, this is exactly what Emma has. So I then called to our local pediatric hospital and said, my daughter has PANDAS. I really need help. Do you have someone there? And they promptly told me they didn't believe that that was a thing. And I said, thank you, and hung up. We kept looking. Ultimately found someone in New York, which is quite a distance from Indiana. So my wife and Emma got on a plane, went to New York, and sure enough, the doctor took one look at her and said, yes, this is PANDAS, and I think she needs IVIG. She's very severe. And so they came back. And so I thought, oh, well, good, I have an answer. So I decided to call a pediatric neurologist and said, look, I know you do IVIG for other things, and this is my daughter. This is her story. It's what's going on. At which point he said to me, it sounds like she just needs to be on antipsychotic medicine and put into some type of residential treatment. And I just said that doesn't sound right. Like she was normal a month ago. I don't understand. And so I said, thank you once again. And we ultimately kept looking, and I found someone in a neighboring state to Indiana to give her IVIG. So she got her first IVIG infusion. And 4 days later, her symptoms were gone, completely managed, anxiety down, OCD, all but gone. And at that point, I just, through studying and seeing what happened with her, I just felt like I didn't want this to happen to anyone else. If it can happen to us, and we were both physicians, I felt like it must be much worse for folks that didn't know how to kind of navigate their way through this. And at that point, I decided my specialty had found me, and I dedicated myself. I had already been board certified as integrative medicine at that point, as well as working in the ER. And so developed, kind of branched out upon the program that we used for my daughter, and then ended up doing what I do now. So, okay. If at any point there's any technical difficulties, people can't see my slides, then just let someone know in the chat and they'll let me know and we'll help you out.
Yeah, you're good. We can see your slides.
Perfect. So I'm supposed to present these first few slides. I have no grants or anything that I know of that's going to impact my talk in any way. I've received no financial or in-kind support. I have no payments or funding from any organization that's being discussed, and I have not identified any bias. So today, what we're going to talk about, it's going to be a bit of a whirlwind as we go through this. So I'd like to leave some time for questions. We're going to learn about the definitions of PANS and PANDAS, common presentations, diagnostic criteria, also the role of molecular mimicry in autoimmune diseases, and some concepts of immune dysregulation that kind of are at the bedrock of why this happens. We'll talk about laboratory and radiology testing in PANS, what the utility is there, some common infections, toxin, and stressors which may precipitate flares, and then 4 areas that I talk to parents about this at every visit that we really need to successfully treat to see good long-term recovery in PANS and PANDAS. So some quick definitions. PANDAS stands for Pediatric Autoimmune Neuropsychiatric Disorder Associated with Strep Infection. PANS stands for Pediatric Acute Onset Neuropsychiatric Syndrome. So PANDAS is associated with strep. PANS is sort of the parent umbrella that includes PANDAS plus other infections that we'll talk about in a bit. So some myths. Some of these you may have heard. They're rare disorders. Probably not. The concepts are newer, were invented in the 1990s. Also not true. Also, you may have heard there's no scientific evidence that infections can cause neuropsychiatric symptoms outside of maybe encephalitis. The diagnosis of and treatment of PANS and PANDAS are not evidence-based medicine. It's not true. In fact, when I wrote my book, there's 1,200 references from the peer-reviewed medical literature in there kind of to counter that. I've provided the medical education office with an annotated bibliography that you can have. The bibliography contains over, I think it's 300 references from the peer-reviewed literature to support the portions of my presentation. So a roadmap. Today we're going to talk about stop one on the roadmap is the history and science behind PANS and PANDAS, then the diagnosis, then evidence-based testing, and then finally evidence-based treatment in PANS and PANDAS. So the history and science behind PANS and PANDAS. So in your immune system, this is where everything begins. It's not simply the infection. So PAMPs, pathogen-associated molecular patterns, either carbohydrates or proteins from pathogens, act as triggers to the immune system. They activate innate immunity, of course, barriers, cytokines, natural killer cells, and then ultimately adaptive or acquired immunity, you'll remember, occurs afterward, involving T cells and B cells. So immune dysregulation, or really immune deficiency, can result from a defect in any of those previously mentioned defenses and probably other steps as well. Autoimmunity is sort of the other side of the coin when you have, I guess, an over-exaggerated immune response or activation against self. We know that there's a genetic risk. Certainly, certain autoimmune diseases will run in families. So the mechanisms. So the intestinal and cutaneous microbiome contribute. Also, increased intestinal permeability contributes to autoimmunity. There seems to be some bystander activation of the immune system, which will damage otherwise healthy cells, innate cells. And there's this concept of molecular mimicry, which is sort of the biggest piece of this, and it's what fits in with PANS and PANDAS. So molecular mimicry basically says that there are shared molecular appearances between microbes and self tissues. In fact, in 1995, there was an interesting article in the American College of Rheumatology Journal, which was on mechanisms of autoimmune disease induction. And it mentioned molecular mimicry, stating basically that microbes and some mammalian cells probably share T cell epitopes. They also mentioned in this article, microbial infection could alter antigen processing and presentation to promote cryptic self-recognition, autoimmunity. And they mentioned immunologic cross-reactivity between microbial antigens and self-tissues by serum antibodies has been demonstrated experimentally in many situations in humans and in laboratory animals. Additional papers were cited by this paper, which affirmed the concept of molecular mimicry, including one from as far back as 1964, which spoke about shared antigens between a parasite and a host. So the question is, first, since PANDAS was kind of the first thing that began the conversation, how are streptococcal infections related to autoimmune neuropsychiatric disorders? So we're all familiar, of course, with group A beta hemolytic strep causing pharyngitis or cellulitis, bloodstream infections. There are also toxin-induced complications, scarlet fever, and there's a streptococcal toxic shock syndrome, not as well known as staphylococcal toxic shock syndrome, but it does occur. And then there are these non-suppurative complications like post-streptococcal glomerulonephritis, and then also rheumatic fever. So rheumatic fever, at least in the United States, is pretty rare occurrence now, but similar symptoms to rheumatic fever were described as far back as 400 BC. Most commonly now, if it does occur, rheumatic fever is between the ages of 5 and 15. Interestingly, the same kind of group where it's most common to obtain the diagnosis of PANDAS. Now, in rheumatic fever, there's a delay sometimes from strep infection to symptom onset of up to 5 weeks. Currently, the diagnosis occurs using the Jones criteria. And in most cases, there should be a preceding throat culture. But since there's a delay in onset, if you have something suggestive of rheumatic fever, then you would treat even if the presenting test may be negative. So these patients present with carditis, polyarthritis, rash, subcutaneous nodules, and a movement disorder called chorea, specifically Sydenham chorea. The pathophysiology is thought to be group A strep. There's a genetic predisposition and molecular mimicry by T and B cells. So antibiotics are sort of the treatment of rheumatic fever. As I mentioned, they sometimes treat even if the initial testing is negative since there's a delay. And the current practice is long-term prophylactic antibiotics. There's a bit of a controversy in literature on this, but Sydenham chorea is what occurs as part of rheumatic fever. It's a movement disorder. It was first discovered in the 1600s, linked to rheumatic fever in 1802. But this can occur up to 9 months after strep infection. So you can imagine it'd be difficult to link the two. And the recovery for Sydenham chorea can be prolonged in some patients. So we know also that this occurs due to molecular mimicry. The strep carbohydrate tends to cross-react with neuronal structure, seems to have a similar homology. Interestingly, anti-neuronal antibodies are present in 100% of patients with acute chorea, but not seen at all in controls. Tubulin seems to be the particular neuronal target of these autoantibodies. In these cases, MRI shows increased size of the basal ganglia. CT and MRI show reversible striatal abnormalities which clear after recovery, and PET scans can show hypermetabolic changes in the basal ganglia. So treatment, as I mentioned, immediate and prophylactic antibiotics. This improves things, and also IVIG is given for Sydenham chorea, which can be quite effective. Interestingly, OCD occurs with Sydenham chorea as high as 82% of initial episodes. If you have recurrent chorea, the OCD incidence becomes 100%. It's also been associated with other neuropsychiatric illnesses, as you can see, including cognitive issues, mood issues, and even what looks like psychosis. So there was an August 2019 review which mentioned that in some subset of patients with OCD, it's likely that autoimmunity is likely triggered by specific bacterial, viral, parasitic agents with overlapping surface epitopes. There's that term again. The first sort of modern discussions about PANDAS started maybe in 1994 with Dr. Susan Sweeto, president of the U.S. National Institute of Health. She published an article in Pediatrics talking about children with Sydenham chorea, Tourette syndrome, or OCD. And they also mentioned that they thought neuroimmunological dysfunction could occur due to these anti-neuronal antibodies. The antibodies were thought to be to group A strep. So this is how this starts feeding together into where we got to where we are now. In 1997, they published in the American Journal of Psychiatry an article with Dr. Sweeto again. It focused as strep as the inciting event in some folks, and it coined this term PANDAS that we had talked about before. The diagnostic criteria at that time, onset, they mentioned age 3 to puberty, although I can tell you we've seen it in older kids and even in adults at times. OCD, episodic course of symptoms, temporal association with an infection, and then other neurologic symptoms, including adventitious movements, including chorea-form movements. So they were not sort of the chorea that we see in acute rheumatic fever, but sort of a similar kind of piano-playing chorea-form movement. So also in 1997, they published a study on the first 50 patients, same diagnostic criteria, 50 patients with 144 episodes, so waxing and waning. They also commonly found emotional lability, separation anxiety, nighttime rituals, cognitive deficits, and severely oppositional behaviors. So MRI of children, if you think back to what we saw with Sydenham chorea, in these same children who met PANDAS criteria, they studied 34 children and then 82 healthy controls and found that the basal ganglia, the caudate, putamen, globus pallidus had hypertrophy, which was, or larger size, I should say, than controls, similar to the area we saw in Sydenham chorea. And some initial studies were done with IVIG for PANDAS. The initial one, and I'll mention some later, the more recent studies, but this initial one was done in 1999, a small study in the Lancet, 29 children. And they did baseline 1 month, 12-month assessments. About a third of them got plasma exchange, a third got IVIG, a third got placebo. There was no improvement in the placebo group. So these aren't things that sort of wear off when you get treatment many times. But OCD, anxiety, overall functioning, and tics were better with these treatments. And in 82% of the patients were still very much improved at 1 year. There's an interesting tiny little study. I just like this study, but they took sera from well-characterized PANDAS patients and then matched controls, and they ejected them in the striatum of mice, in the brain of mice, and did this immunofluorescence microscopy. These striatal neurons that they injected them into were implicated in some tic disorders, and what they found was PANDAS, serum from children with PANDAS bound to 80% of cholinergic interneurons. Healthy controls had less than 50% of binding. And after IVIG treatment, they did the same thing again, and the elevated binding resolved in these mice. So initial antibiotic studies were done in 2002, and a lot of these children had a negative strep test prior to the initial onset, and they were treated with antibiotics targeted against group A beta hemolytic strep. Immediate resolution was seen in many children, and 50% of the children, when they had strep again, had symptoms return. So PANS, where did we get PANS? So in 2012, there was another article from the National Institute of Mental Health. 6 clinicians from many treatment areas, academic centers, community hospital settings, and also private practice. More than 400 PANDAS type patients. They discovered or reported that these symptoms were very abrupt, ferocious, and overwhelming. Sometimes I will get a call and a parent will say, my child is kind of a picky eater. Could this be PANDAS? And I'll say, you kind of know if it was PANDAS if it's PANDAS, because it's disrupts the entire family. Many cases, though, in these 400 patients were documented after other infections which weren't strep. So mycoplasma and other things. And they term this pediatric acute onset neuropsychiatric syndrome as, it can be strep, PANDAS, but it can also be other things. So the question is, can other infections, we studied kind of this link with strep and carbohydrates and PAMPs and all these things, but can other infections in the absence of meningitis or encephalitis cause neuropsychiatric changes? So influenza. So influenza was linked to OCD as early as 1917. After the Great Flu of 1918, Dr. Konstantin van Economo wrote about this phenomenon in the 20s of encephalitis lethargica, he called it. There were similar cases described later in 1987 where they noted basal ganglia involvement, so that kind of tickles my ear that maybe there's a similarity here. But further studies were done on preserved tissue samples recently, and they found no flu organisms in the brain. So it wasn't merely a parasite, or not a parasite, but a virus causing an issue in the brain. There seemed to be some autoimmunity here. And what's interesting is he wrote, subsequently, von Economo wrote about a variant, pseudo-psychopathic variant, he called it, of encephalitis lethargica in children, ages 7 to 17. And he said children with this phenomenon presented with a wide variety of behaviors that were regarded as aberrant, delinquent, or in extreme cases, psychopathic. He goes on to describe they skip school to attend movies, I think I remember, and steal penny candy, etc. The sad thing about these cases were many of these kids were placed in state institution, and some were lobotomized. So we've seen neurologic complications in 2009 with the H1N1 outbreak in the United States. Also, recently, just this year, we've seen several kids have extreme flares, even initial onset of PANS after influenza A. I don't know what it was this year. Normally, influenza is not a big deal. COVID hasn't been as much of a big deal. Mycoplasma. So we know that mycoplasma antibodies have been seen in higher amounts in children with Tourette syndrome. There are also some case reports from the Journal of Child Neurology of children with mycoplasma pneumonia that then developed OCD, which resolved once it was treated. There are additional reports of children who had pre-existing vocal and motor tics, which then got worse after having mycoplasma. And mycoplasma encephalitis, we know, attacks the basal ganglia. I can tell you in our practice, several hundred children, we see eating restriction, which is part of the criteria we'll talk about in a minute, associated strongly with mycoplasma infections in these kids. So Lyme disease. So Lyme disease, we call the great imitator. As we all know, it can affect many different bodily systems. There's a wide variety of symptoms. We all know that it causes rash, Bell's palsy, joint pain, carditis, and cerebritis. But it's also been shown to cause cognition, memory issues, attentional issues, OCD, hallucinations, etc., psychosis, and even depression. So Borrelia epitopes cross-react with human neural tissue from the brain, spinal cord, and dorsal root ganglia. That's the tie-in sort of with Bell's palsy. Antineuronal antibodies are seen in patients with persistent symptoms of Lyme disease even after treatment. Central nervous system inflammation and glial activation is seen. We also see that in children with PANDS. And early glial cell invasion and disruption of the blood-brain barrier is seen in early Lyme. COVID. So COVID neuropsychiatric symptoms are usually related more to the response of the body to infection due to inflammatory cytokines. There seems to be an interplay, as we all know, between COVID and increased coagulability, and blood-brain permeability is increased due to cytokine damage after COVID. So there was a retrospective study in the US of over 1.2 million patients. It was published in Lancet Psychiatry. And they found that patients who had COVID had a persistently increased risk of several psychiatric illnesses, as well as cognitive deficits and epilepsy in the 2-year follow-up period. We've seen minimal change, thank goodness, to COVID in children in our practice. We've not seen this be a major flare. I was living in fear in 2020 and 2021, and we just didn't pan out as much. So toxicants. So toxicants are man-made environmental pollutants that we're all exposed to. We're all kind of been hearing about forever chemicals lately. But we know from the archives of toxicology that environmental chemicals can impair or stimulate the immune system. We know that there's issues due to pesticides, and also glyphosate itself has been specifically shown to impair the immune system. Heavy metals. So we don't think a whole bunch about this since lead was taken out of gasoline and out of most paint that we would use. But even high normal levels can affect neuropsychiatric function in children and can adversely affect the immune system. So how do we diagnose this? So this is one of the major points I'd like you to walk away with, which is it's a clinical diagnosis. It requires no lab work. It requires no MRI or anything else. Those things can be helpful, and I'll tell you why in a bit. But it's a clinical diagnosis. So the classical criteria, and I also always put classic in kind of quotes, because I had a very wise emergency medicine residency attending who once told me, never punish the patient because they can't tell you a good story. So sometimes patients don't present classically with these criteria, but if they have a lot of these things going on, something's happening, and the workup can be sort of similar. So classically, you have an abrupt, severe, sudden onset OCD or restrictive eating with the presence of at least 2 of the following 7 criteria groups: anxiety, emotional lability or depression, irritability, aggression or oppositional behaviors, behavioral regression, baby talk, things like that, deterioration in school performance, sensory or motor abnormalities, looks like sensory integration, and somatic signs and symptoms, issues with urination, frequent urination. But this little asterisk that's in yellow down here, not better explained. I always like to mention to people, we need to also make sure there's not another known neurologic or medical disorder that's causing these things. And, if you were to have a child who's lethargic or obtunded or just going downhill, that's a child that needs immediate evaluation and doesn't belong in my office. So sometimes children need an MRI or CSF studies, an EEG, an echo or EKG if you're entertaining the diagnosis of rheumatic fever, or some specialty consultation. If they can't swallow, they may need a GI evaluation, gastroenterology. But remember this. So I'll talk a little bit about the symptoms. Remember, these children are extremely ill. Everything is extreme. These are extreme compulsions. With OCD, they will have fears of contamination, hand washing, fears of harming someone. They will say, I'm afraid when you weren't looking, I put hand sanitizer in your drink. Checking, repeated checking, or asking their parents for reassurance. Am I sick? Am I clean? Is this dirty? Is this food okay? Or magic words. When the parent answers them, the parents must say, yes, sweetie, like to every question. It can't just be yes or yeah. Religious or sexual thoughts are common. One of the things I'll tell parents and older children when I see them is, people when they have OCD, and I had OCD when I was about 16, when people talk about OCD, they'll tell you about the socially acceptable compulsions and thoughts. They won't tell you about the other stuff. And many times these kids will have thoughts about sex, naked people, killing, suicide. And I always tell parents that that's, thoughts are just thoughts. And I'll tell kids this as well as a way to reassure them that, it can really, and you have the sense when you have OCD that that the thoughts you're thinking are strange. And so that there's a lot of shame that goes along with that. So I always try and reassure these kids, thoughts are just thoughts. Your brain's trying to protect you in a way it doesn't need to. But I'll tell parents, don't necessarily push to hear the specific content, because it's like bugging someone to hear what their dream was about last night. Like, does it really matter? This is a picture of my daughter's hands when she was at her height of illness, which she kept trying to convince me this was just from winter time, which she had never had. It was from washing your hands compulsively. Severely restricted food intake. This is not a picky eater. This is a child who talks about, I'm going to choke if I eat. They will lose weight. In severe cases, they will need hospitalization and a feeding tube. Anxiety usually is associated with the OCD. Emotional lability and depression, it can be very sudden, can be volatile, out of nowhere with no trigger, seemingly. Suicidal thoughts can be common, and you will see a lot of severely oppositional behaviors. But in my mind, those are OCD and anxiety driven. So I would say to you, if I took you and put you in a cage with a lion and then blocked the door and wouldn't let you out, if there was a chair in there, would you sit? Even if I told you to sit or commanded you to sit or said, you're going to sit because I tell you to sit, all the things parents might say to get a child to comply. No, you'd become physically assaultive and aggressive and non-compliant, or whatever you want to call it, irritable, to get out of there, to save yourself. And these kids, OCD is a safety-seeking behavior, and OCD comes from the primitive part of the brain, and fight or flight comes from the amygdala. But the thoughts aren't simply, I have to wash my hands because I'm dirty. It's kind of like dirt equals death. And that OCD will exaggerate the risk of things, and that's why these kids look so wound up. You'll see developmental regression, baby talk, selective mutism, new stuttering, also deteriorations in school performance. ADHD, these kids will get diagnosed with memory issues, but remember, not delirium. This is one of my patients on the left. These are freehand drawings that she did before she was sick. And on the right was her best effort in our office to draw something. You'll also see tics. So tics are really self-soothing. They are the only movement disorder that's suppressible. So there is almost an OCD quality to them. And you'll see a lot of clothing aversion, sensory amplification. They will not want to hear loud sounds or people chewing. They'll say it's not right when you're trying to get socks on these kids. And then you'll see lots of sleep disturbance. Usually they will want to sleep, have the parents sleep in their room, then sleep with the parents. Kind of strange. It's just a thing they do. And then lots of bedwetting, daytime wetting, urinary frequency. And what I always say is, if you look at symptoms and signs of illness, right, when you get the flu, and you vomit and you have diarrhea and you have a fever, none of that's caused by the flu. That's caused by you. It's caused by your immune system doing what it's supposed to do. Let's empty the bowels and get rid of the virus. Let's cause a fever to burn the thing down. So these kids, lots of times, the only change you'll see is behavioral when they get sick. So their sibling has strep and has a sore throat and a fever and a rash and whatever. They just go off the rails behaviorally. And then when they're taken in and tested, they have strep. So the normal signs and symptoms of illness are absent. So in essence, it's part of the immune deficiency portion of this. So I always say and reiterate, if they have prominent delirium, psychosis, encephalopathy, those are patients that don't belong in my office. They belong in an emergent setting and be worked up. Seizures, things like that. None of these things none of them go along with PANS or PANDAS. In 2013, there was an article, the PANS Consensus Conference. There's a large group of physicians from many different care settings. They confirm the clinical criteria. They found a greater than 70% incidence of both psychiatric disorders and autoimmunity in family members of patients with PANS. Found an 10 times increased risk of OCD and tic disorders, and also increased risk for rheumatic fever in the family. So some physical exam pearls, vitals and hydration status, very important. Doing a visual exam, looking for Kaiser-Fleischer rings for Wilson's disease. Also, palatal petechiae or other signs of strep. Facial and eye tics can be subtle. I remember when my daughter had kind of an eye-rolling tic, and I missed it, of course, before I did any of this. And I used to say to her, like, you're a teenager, you need to get better at rolling your eyes than that. Of course, now I feel like an idiot, but heart murmurs, evidence of hand washing or perianal strep. It's important to look for it. If you don't look, no one else will. Romberg exam, you should be able, finger movements, especially kind of the piano-like finger movements, choreiform stuff, are rare in children over 8 years old. Normally or minimally depressed reflexes, and writing, drawing, or copying figures may show you a difference from their baseline. These kids look worried, tremulous, hyperreactive. They're in sympathetic overdrive. A deer in the headlights is a good example of it. So what do we do in terms of testing? So the purpose of testing, not for diagnosis, but to rule out other diagnoses, to give you an initial direction to go in, and to guide the trajectory of the therapy. So MRI, EEG, echo, EKG, those things if needed. It's not every patient. Specialty consultations if needed, not every patient. We typically do what you would normally do. So CBC and a CMP, C-reactive protein and a SED rate I used to do all the time because these are inflammatory disorders, right? They're rarely positive, and I'm always trying to save the amount of blood we're doing. So I don't do those many times anymore. We do look for celiac, so you can have central nervous system changes with celiac disease. Important not to miss that. Iron and ferritin we check, especially with sleep disturbance. We check thyroid testing and especially anti-thyroid antibodies. You can see autoimmunity begets autoimmunity, so many of these kids will have signs of thyroid autoimmunity, celiac disease. And then we check for nutrients, 25-hydroxyvitamin D, methylmalonic acid, for B12. We check RBC, zinc, and magnesium. About 40 to 50% of these kids have a positive ANA. Now, what do we do with that? Not a lot other than it's an indicator, kind of a confirmatory test for autoimmunity. We will follow it, and typically over time with treatment, it will become negative. Quantitative immunoglobulins. These kids are deficient about 48% of the time in IgG, typically IgG or subclasses, sometimes IgA. The reason I really do this is to get IVIG approved if I decide to do that, because if they have a common variable immunodeficiency and frequent illnesses, it can cover. And then also looking at vaccine responses, 23 serotypes, pneumococcal vaccine, or diphtheria or tetanus titers. So a lot of times these may be absent, once again pointing to the immune deficiency. So there are some autoimmune encephalitis panels. We do a conventional panel that's got NMDA and GAD65 and AMPA and things. There's also a commercial panel available I won't mention, but I can answer that question later. I don't do it very commonly. It's got an 88% sensitivity, 83% specificity. It doesn't really change anything. It's not covered in the US by insurance, and it's about $900. But it's not required for diagnosis. The one time I might do it is if I'm having tough time getting IVIG through insurance, then I may do it. And if there's a positive, then I'll send it back under the diagnosis of autoimmune encephalopathy and it will get approved, which is semantics because PANDAS is autoimmune encephalopathy. But toxin, so heavy metals, I typically will do blood levels or 24-hour urine levels. Some people will test hair and other things. They're really not standardized. I don't do those tests in general. Also, some people, at least in the US, will check glyphosate and other toxins, and I don't test those either. It doesn't change anything, and almost everybody's positive for, we all have chemicals in our stuff, doesn't change much. Mold impairs the immune response. It should be considered if there's been water leaks or visible mold in the home. There's lots of literature, and I put it in the document that I sent you about the fact that mycotoxins produced by molds impair the immune response and can be an autoimmune trigger. Infectious diseases. So when we test for these things, we'll do ASO, anti-streptococcal antibodies, as well as anti-DNase testing. Throat cultures, if there's an abnormal exam or throat pain or fever. I typically don't do it otherwise because it's a big fight. I will do perianal swabs to look for perianal strep if there's signs and symptoms of that. Mycoplasma pneumoniae, I will do IgG and IgM antibodies and IFA antibodies as well. And then I will do an EBV, acute infection profile with early antigen. The monospot testing that we would typically do to look for mono is not very sensitive. It misses some cases. So the question about tick-borne infections, when we're talking about Lyme, in the United States, at least, one of the common things people say is, well, is this a Lyme endemic area? And I don't know the topography or the prevalence of tick-borne illness in Canada, certainly. But this is something that we say a lot because Lyme disease was first discovered in the Northeast in New York, et cetera. And so people will say this, what if you're not in a Lyme endemic area? And my answer to that is dogs don't go on vacation. So this was an interesting study that was done where they compared antibodies to Lyme in dogs to forestry topography and did this Bayesian, analysis. And so interestingly, you can see, almost the entire United States has some amount of dogs that are positive. There's that little strip right in the middle, and that may just be because they're not tested as often. Certainly most in the Northeast, lots in the Midwest. I would argue a little bit that Indiana, which is kind of just below Lake Michigan there, probably is higher than that now. This was done back in 2017. So, two-tiered testing for Lyme using an ELISA and a Western blot has sensitivity of about 50% and only tests for one particular strain of Borrelia. There are many that are seen. Immunoblot testing is a lot more sensitive. There's another company we use for that. Evidence-based treatment. So once you've obtained the diagnosis and if you've obtained lab work, what do you do? So there's these four components of treatment that I always emphasize: finding and eliminate infections, finding and removing toxins that are going to impair the immune response, re-regulating the immune system, and then breaking these neurologic loops. So empiric antibiotics are usually initiated initially and for flares. The duration of therapy can be prolonged. Obviously, we're all into antibiotic stewardship. It was one of my big arguments I had in the ER constantly when patients came in with the virus wanting azithromycin. It was one of the things I always argued with people about. But these kids are sick, and it's a longer term thing. And many times they have infections are persistent because they live in biofilms. And so it can take a longer period of time. In biofilms, which are like that gooey milieu that strep makes, Lyme makes, it's seen in mycoplasma, the resistance genes can be passed, and so it can take longer for things to work. There are biofilm disrupting agents you can use. Broad spectrum digestive enzymes and serrapeptase can be helpful. There's available as supplements, obviously, in the US. And then a lot of times we will use herbals. They help shorten the duration of antibiotic therapy. That's especially true for mycoplasma and for Lyme, not as much for strep. Antibiotics have been shown in studies to shorten flares of people when they have PANS. Testing really can help narrow therapy or change directions, as I mentioned. There's also a probiotic that's available. It's available on Amazon, but it's Strep salivarius K12. So it's a helpful type of strep that studies have shown prevents adhesion of strep to the mucosa. So a good question that I get quite a bit is, how should we choose antibiotics initially? Some people might initially start with azithromycin. Other people might start with a beta-lactam of some type. And so some people use cephalosporins like cephalexin or ceftonir. There's some basic science that indicates the clavulanic acid that's in moxilin clavulanic preparation. I'm not sure what's called in Canada, but there is some indication that may have some neurological membrane stabilizing properties. So some people will choose augmentin for that reason, and then some people will choose azithromycin. It's once a day. It's easier to take. But what we use in our practice, and I don't have a slide in here, but we have initial antibiotic selection. So it's got different criteria and we kind of score it. So if, for example, they have a lot of ticks, that usually will indicate that it's strep is the dominant organism. So we will treat with kind of a beta-lactam or cephalosporin. If they have more eating restriction or something else to suggest mycoplasma or Lyme or something, we may treat with azithromycin. What about tonsillectomy? So there are some PANDAS physicians that will do tonsillectomy on everyone. And it would seem logical, right? Like if you're getting recurrent strep, let's take the tonsils out. Well, anecdotal reports and parent satisfaction, small case studies have shown some satisfaction with this, and some almost near miraculous, like we operated on these 6 children and then they never had a flare again. And that definitely does happen at times. But prospective studies, there was one done, I think in Italy, maybe, where they took, I think it was 140 kids and split them right down the middle. Half got a tonsillectomy, half didn't. There was no difference in flares afterward. And I'll recommend it if I have a child and their strep antibodies are positive, and we're just treating them, they're just not getting better. Sometimes I'll suggest to the parents, and we've had a few cases where so I think that's why the literature shows that overall, there's not really a particular improvement, but in some people, I think that's what we're seeing. So re-regulating the immune system, we use low-dose naltrexone quite a bit. It comes from a compounding pharmacy. It's related to naloxone. Naltrexone's an oral form. You all may be familiar with it in the setting of addiction. In higher doses, 50 to 100 milligrams. But in smaller doses, this is a dose for adults, 1.5 to 4.5 milligrams, even lower in kids. But it reduces autoimmunity. It tends to improve immune deficiency, kind of balancing. You can sometimes see stimulation at night if you give it at night, or vivid dreams, sometimes headaches. So we either lower the dose or give it in the morning. Steroids, I'm not a huge fan of steroid treatment for PANS and PANDAS. Obviously, you can't use steroids long-term, as we all know, but about 50% of the time, it will cause a lot worse anxiety. If you have an aggressive kid, they'll start punching holes in the wall. So you have to be a bit careful. They have a time and a place. IVIG, has to be given typically first at an infusion center. If they tolerate it okay, we will allow them to have additional infusions at home. I have a very detailed protocol with orders in my book. You have to stay really well hydrated before and after IVIG. We discharge typically with oral steroids and ondansetron to prevent vomiting afterwards or headache. It's expensive in the United States, very difficult to get insurance coverage. It's considered investigational in a lot of places, but multiple studies since the initial one in 1999 and clinician experience demonstrate efficacy. There's additional evidence you can see here, 2018, 21, 22, 23. All those references are in the document that I had sent to share with you. In terms of breaking neurologic loops, when we talk about OCD, exposure response prevention outperforms meds in some studies in kids. It interrupts the sort of intrusive thought ritual cycle. It needs to be done really at home repetitively and not just an hour a week, because the kid will kind of hold it together if they're in your office once a week, have an ERP, and then go home and just. So a reward or almost currency system we use based on an intensive outpatient program my daughter went to in Chicago while we were going through all this. It was helpful. We use something called the point system. And so that is helpful. This is actually on the left there. The girl in blue is my daughter. And this was her intensive outpatient treatment center. That's a dumpster, a garbage dumpster behind the hospital. And one of her final exams, if you want to call it that, was go out and touch the dumpster for 15 minutes. She had terrible contamination OCD. And this picture on the right still kind of gets me a little. When we were in Chicago where her IOP was, we went to Six Flags or whatever it's called in Chicago, amusement park. And she wouldn't touch anybody for the entire time she was going through this. And when she finished this program, we were walking and she spontaneously put her arm around my wife. And I nearly cried. I took this picture. So medications, SSRIs are effective and a lot of times can increase appetite in kids when they have restrictive eating. Occasionally antipsychotics are used, but sometimes patients get activated with them. I occasionally use these in practice, but usually in consultation with child and adolescent psychiatry. Hypnosis. So in younger kids, I've used this in the office with needle phobia. It's really well studied in the literature for this. I've used it in older children as well. I had one girl who came in with selective mutism. I'd been treating her for a few years, could never get her to talk to anyone except her mom for 3 years. And I brought her in and did a single hypnosis session with her, and she talked and has talked ever since. Self-hypnosis, there's a program for that online program that I can mention later in the questions if you wish, which can really help with nocturnal enuresis. It's self-hypnosis for kids. Other adjuncts, I use a lot of hypnotic language with parents and kids. Identity cues, telling parents to help their child view themselves as a healthy person with some things in the way. And I tell them I'm the get out of the way guy. I help get this stuff out of the way so you can go on with your life rather than you're sick and you have PANDAS and all that kind of thing. And also have parents say when they start getting better, back when you were sick, back when you were sick, you could never sit at the table and eat dinner. I'm so proud of you. Things like that, kind of putting a lamppost in the ground for the kids. And that really falls under the realm of neurolinguistic programming. I use a lot of that with kids, kinesthetic anchors, things like that to help with relaxation. Nutrient replacement. Nutrients are needed to make neurotransmitters and modulate immune health, especially in kids who are not eating well. Dietary changes. If there's no food restriction, we will recommend reducing inflammatory foods and doing a trial of gluten-free diet and removing processed foods and junk. NSAIDs can be helpful, either ibuprofen or naproxen sodium. I haven't found one to be better than the other. Curcumin can help. It's natural. And then remember, the microbiome itself trains the immune system for how to react. And so probiotics, especially if a child's on antibiotics, we will include in there. Family counseling can be helpful. This is a whole family thing. School support, at least in the United States, we call it an individual educational plan or a 504 plan, but school support's important. And then narrative support for parents to help them deal with family and friends. We all have well-wishing family and friends, and a lot of times these kids, your family sees them and they're reacting this way, and the family's like, they just need a little swat in the bottom and they'll straighten themselves out. And it's not the case with these kids. They're scared. And so it almost looks a little like permissive parenting, and you've got to coach them through this. PANS on PANDAS really became controversial in the mid 2000s. I think initially, the initial round of information, people were like, yeah, I can kind of go with that. But then people are starting to notice some of these kids didn't have a positive strep test, or look, a lot of these studies are small or retrospective. And they were saying, one of the big defenses people will put up when they want you to stop talking about anything new is, oh, that's not evidence-based medicine. But what's interesting is Dr. David Sackett, who originally wrote some of the articles in the United States about evidence-based medicine, wrote an article in 1996. The initial articles on EBM came out in maybe 91. I think Guyot wrote an article in the Internal Medicine Journal Club. But Sackett wrote this article because of what he saw happening with EBM. And he said, basically, in order to have evidence-based medicine, you need three things. You need the best available published evidence, meaning that there might not be any published evidence. You need compassionate sensitivity to patient desires and preferences. And then lastly, the clinical experience of the physician. And he said, evidence-based medicine is not cookbook medicine because it requires a bottom-up approach that integrates the best external evidence with individual clinical expertise in the patient's choice. So the future of medicine really is personalized medicine or precision medicine, where we're taking all these things and not just the 40,000 patient, article. Patient with PANS and PANDAS require an entirely different approach to mental illness. And I think that's the real reason why it's become kind of controversial, is because for me, looking back on how I might have treated people in the ER over the years, and just defaulted to something when maybe there could have been something else at play is the thing that kind of still bugs me at times. But, so this attitude sometimes came about that, look, PANDAS, they don't exist. It's what I was told. Despite very congruent patient histories, these kids look the same. Everyone you see practically. Physiological and imaging data, we talked about the studies listed above. There's 1,200 studies in the book I wrote. And then the clinical experience of a lot of people at academic and community centers all over our country, all over the world. Unfortunately, a lot of those sentiments permeated medical education throughout the United States, likely beyond. The incidence. Some people say it's as many as 1 in 200 children may have some element of infection-mediated autoimmunity and neuronal antineural antibody. So it's critical, really, that we change our paradigm because many patients and their families are really, really suffering because PANS and PANDAS exist. So this is a call. We have to really listen and trust our patients and their parents. We have to get curious about what's going on, and we have to practice evidence-based medicine and understand really what that means. Future directions, I think, there are state and national campaigns in the United States, at least, to prevent insurance denials for IVIG, physician and other healthcare provider education, more coming on that within this coming year. I'm going to be probably offering some additional trainings to help you because I can't see everybody. And the other physicians that are doing this work, it's not just me, but we can't see everybody. We need to kind of get the message out. And there's additional work being done with rituximab and other immune modulators and targeted therapies. Thank you.
Wow, thank you very much for this very richly informative and thought-promoting presentation. Before we go to the Q&A, this is just a reminder that these rounds are accredited by the Royal College of Physicians and Surgeons of Canada and the College of Family Physicians of Canada if you are attending the live presentation. And that we also, this will be on the next slide, remind you to do your evaluation. The Grand Rounds Committee, we do look at all of the evaluations to inform our Grand Rounds. So I want to open it up for Q&A. Okay, sorry, there's a Q&A and then there's also a comment in the chat. Dr. Karen Hapshin, who is actually our infant and preschool psychiatrist, it sounds like she recommends blind spots when medicine gets it wrong, explaining why medical practitioners delay on acting on evidence. Yeah, that's the thought-provoking part of this presentation. So Renee, if a child has recurrent strep infections as a young child and develops severe anxiety and some OCD symptoms which remain into their teens, even if a diagnosis of PANDAS can be confirmed, would it be too late for treatment specifically for PANDAS since so much time has lapsed since?
It's a great question. It's a question I get a lot. because occasionally we will see somebody into their 20s. What I think is important about this message, getting the message out, is that we want to see these kids sooner. Because if I see a child that's, had these symptoms for 2 months, they're going to probably be better within 6 months. If I see someone who's had symptoms a lot longer, then it's harder. In that instance, when we see those people and they're young adults and they come in and see us, obviously we're looking for ongoing infection. We're looking to see what their immune system's doing. The other piece to remember is at that point, OCD being a safety mechanism ends up being sort of a cemented way of life. And so it can be hard after a period of time, overcoming some of those things, even with CBT or medications or whatever. So that as a child, I would definitely do a workup on. And yes, to answer your questions, we've seen people who've been affected for years, have some recovery, because many of these infections can be biofilm infections. There can be other infections. And really, the thing to remember is it's really a disorder of immune dysregulation. So many times, maybe the first thing that started this was strep. But then we eradicate the strep, they're fine. 3 months later, they get influenza A, and the exact same thing happens. There's interesting articles by Dr. Robert Navio, PhD, in the journal Mitochondrion on something called the cell danger response. And it sort of describes cytokines and how your immune system responds to things. And he says basically there's a durable metabolic memory within your mitochondria of your cells. So when you have an infection or a trauma or something, even physical trauma, and you respond to it in a certain way and you get over it, your body then takes that as almost a blueprint for an immune response. That may be why someone would say, every time I get the flu, like I have a fever of 106 and I feel awful, whatever that is in Celsius. I don't know. Sorry. But anyway, 41 maybe. Anyway, that idea of a metabolic memory may explain why, people come in, and even psychological trauma. So sometimes these kids will come in and the parents will call me and they're like, they just started school and they're flaring. And I used to think, oh, I guess they just got infected. They just need an antibiotic or something. What I've come to understand is that a lot of those things can trigger that cell danger response, and you can have this metabolic response that looks exactly like an infection. So I've kind of learned my lesson to test and figure things out and try and be thoughtful about that. So I'm not just slapping someone in antibiotics every month and a half. So good question.
Thank you for that. And I actually don't know if Renee is a physician, but thank you for the very good question. Dr. Matthew Morissette, thank you for the comprehensive overview. He's heard mixed opinions from expert colleagues regarding the usefulness or potentially lack thereof of the Cunningham panel, which comments regarding when or if to consider this panel.
Yeah, and that was it. Just because this was a CME presentation, I'm not sure how it works there, but in the United States, we can't mention names of things, trade names, if we're giving a presentation. So, but in Q&A, at least where I'm from, it's allowed. So Cunningham panel is what I was referring to in my one slide where I said commercially available panel. So we use a panel typically through our regular labs like LabCorp, Quest, or in the United States, or the Mayo Clinic has a panel. But the Cunningham panel is a separate panel, and many parents will come in and ask for it. It's 4 different antineural antibodies plus CAM kinase, which is an enzyme. And if you have elevations in these, it suggests these are antineuronal antibodies that have been studied with PANDAS in the basic science context. And there are practitioners that say, you got to do it every time. And what I say is, anytime someone tells me to do a test all the time, I say, how's it going to change what I do? And the Cunningham panel really doesn't. If it's positive, it's negative. And there are false positives and false negatives. It's like 80, whatever I put on my slide, 83 and 87% false positives, false negatives. So it's not like diagnostic, like, oh, I did the Cunningham panel, they've got it, therefore they have it. The articles to support the Cunningham panel are small studies. They were involving the person who it bears the name of, like involving people, the company that made it. So, and also there's been some recent data they've published that they've said the Cunningham panel predicts a better response to IVIG if it's positive or something. I just don't do it. Like I said, the one time I might do it is if a parent demands it, fine, great. You can spend your money any way you want. Or if I have IVIG and I can't get it approved under the diagnosis of PANDAS, because they'll keep saying it's experimental, Then if I run the Cunningham panel, it's positive, I'll resubmit the IVIG under the diagnosis of autoimmune encephalitis. And I've had that work a few times because I just kind of play dumb and I go, oh, I don't know, this kid has antibodies to their brain tissue. That sounds serious. Sounds like they have autoimmune encephalitis. They need IVIG. And I've had that work a few times. So that's when I might order it. Yeah.
Thank you. Another question from Dr. Habshin. Have you seen PANDAS with parvovirus?
If I did, I might have missed it. I don't test for parvo, so it's interesting. When I went through, wrote my book, I went through all the literature I could find, including Mandel's infectious disease. Like every article, I went pathogen by pathogen because there are plenty of folks that see these kids that order parvo and Coxsackie virus titers and adenovirus and sort of all these things. And the first question I asked myself was, from all the infectious literature, which of these things cause neurologic things, encephalitis, neuro stuff? And I kind of narrowed that down, and I kind of felt like some of them might, some of them not. So the list I came up with was EBV, chlamydia pneumoniae, interestingly, bacterial infection. In chlamydia pneumoniae, there's an interesting statistic with that. If you have antibodies to chlamydia pneumoniae, there's like a 9-time increased odds ratio of schizophrenia. Crazy. We also see schizophrenia with toxoplasmosis. But parvovirus, I couldn't find any evidence of that, or Coxsackie virus. Also, if they had those, I'm not sure what I would do about them. I use some antiviral herbals if they have EBV, COVID, influenza sometimes. There's some antiviral herbals you can use that may be helpful. Things like astragalus or lysine. Things like that can kind of be helpful. It's not in kids. I'm probably not, in the grand scheme of things. Valacyclovir, acyclovir aren't very helpful for those viruses. So I don't really use those. I had one kid that had HSV, I think HSV2, if I remember right, herpes simplex virus 2. I had another child that, I would always order EBV and wasn't sure how it contributed. And I had a young kid that went to college and became psychotic a week after he got to college. And and it turned out that then he became psychotic. I saw him and then developed reactivated EBV after that with like liver enzyme elevations and everything. He had previously had mono. And so it developed reactivation and liver enzymes went up and everything. We treated him, and I treated him with herbs and Valtrex and whatever I could throw the book at him. And he completely resolved. So that's one that I have sitting at my desk that says, write up, Joe's story or whatever. And I just haven't gotten around to it because I'm busy. But yeah, I haven't seen it with parvo. I kind of, I'll tell parents it could be anything. I'll test for the stuff I think we can treat. And there are times where just kind of re-regulating the immune system and getting in order with low dose naltrexone or things like that will cause them to then recover. So sometimes I'll tell parents, I don't know what this was. I've had cases where I've done testing and no infection that I can find, nothing comes back. And then I'm kind of like, well, now what do I do? And I just work on the immune system and decrease inflammation, work a little bit on oxidative stress, which we know there's literature with ADHD and oxidative stress in the brain. So I'll work with antioxidants and do some things, make sure that there's no heavy metals on board, there's no mold in the house, and they'll recover. And so then I say, thank you, God, they recovered. But I don't always know what it is that I'm treating. So I always do my best. And there are cases where I can't find anything infectious, but I'll go on a hunch and I will treat and I'll say, okay, I've got no anything to back this up, but let's try a few weeks of Augmentin or a few weeks of azithromycin and they'll recover. So were the antibiotics having an anti-inflammatory property to them? We know azithromycin does that with astrocytes and neuronal anti-inflammatory. Doxy does that. I don't know, but I'm just wait for when they get better, and I kind of work my plan and plan the work.
Yeah, so I see you err on the side of treating as opposed to
while not hurting them, right? I don't want to take every kid I don't want to take every kid and compel them to some big huge thing that everything has a risk, right? And that's why there are some PANDAS doctors that give every single child IVIG. And it's not wrong, but it's only about 10% of the kids I see that need it. The kids that I'll reach for IVIG immediately for are they're going to kill themselves or kill someone in the house, or they're not eating and like they're steps away from going to be hospitalized. They're losing weight. They're just not eating anything. Those are cases where I'll order IVIG immediately. Otherwise, I a lot of times can wait a little bit. And then just each time I talk to parents, I discuss it. And then if I decide to pull the trigger, I do it. So,
Thank you. We have a couple more questions here.
mhm.
So, Anna Wilson, can recurring pneumonia with pleurisy, body aches, and pain justify an assessment for PANS?
Hmm. Well, I think that if we had recurrent pneumonia, right, with and then, assuming that, we've done diligence in terms of seeing pulmonology, maybe having a CAT scan or a bronchoscopy, depending on what that is. I would say just that narrow, description of recurrent pneumonia with pleurisy, et cetera, not as much. I would be inclined to then think about looking for an immune deficiency, especially if the person's young. Why do they keep getting infections? Do they have an IgA deficiency or a mannose-lectin binding protein issue, or a specific antibody deficiency? And in those cases, IVIG might, in some cases, with CVID is recommended. But I think in the absence of OCD, restrictive eating, severe anxiety, those types of things, I wouldn't as much think of PANS and PANDAS. Yeah.
We do have, thank you. We have one more question. So I do want to, because something you said before, which was
Mhm.
you suggested that I guess older people can also have this. So we're thinking our older teens, maybe,
Yeah.
adults, because I think with the strict definition, they really geared
Right.
towards younger. So then, like, what are your thoughts about, the criteria saying that, it should be, within this age range?
Right. I think, like I said, those are classic criteria. And the only reason I say this is because, once you start seeing these patients over time, and once I do talks and appear places, you get more calls and more calls and more calls. And there are clearly times where I get a call and I'll say, I really don't think this is PANS. Like, I think this is something that might require more of a workup, but I don't think it's PANS. I might get a call and a parent will say, well, my son just failed second grade and he's a picky eater. I think it's PANS. And I'll say, all right, let's talk. And we'll talk it over an hour or so and figure it out. And there are cases where it's not. But I've had cases, as I said, the person that developed that had EBV, he was 20, well, he was 18, he was I'm sorry, he was 21 because he was in his going back for his junior year in college. He had done fine the whole time he had been in college, went back for his junior year, had previously had mono, then developed reactivated EBV and psychosis, like absolute, not psychosis where he was like, needed to be in an inpatient setting, but didn't recognize his girlfriend, severe OCD, um, uh, had some eating issues, was losing weight, had all like he met every criteria, lost the ability to study, met every single criteria. In fact, he was 21, wet the bed in the dorm room. If that's not embarrassing, wet the bed in the dorm room, like had every single criteria, had never had anything any other time of his life. And I said, doggone it, you're 21, but like you meet every single criteria. Came out of nowhere, associated with EBV. We treated him, everything went away. Didn't end up needing IVIG, but we did low dose naltrexone and treated the viral stuff and like tested everything. Everything else was negative. And so yeah, those are cases we've seen, and sometimes we see cases. The original PANDAS researchers, Dr. Sweeto and et al. Wrote one little sentence I think is important in their original articles from the Journal of Child and Adolescent Psychopharmacology in 2013, 2014. They wrote one little sentence which said some adult cases of OCD and anxiety may be missed cases of PANDAS in childhood, which I thought was profound, right? Another scary thing when you think what happened when. It's hard. It's hard. It's
Yeah,
hard,
so having that index of
and
suspicion and getting investigated. Yeah.
so I don't know if I'm assuming you guys may know about the Unabomber, of course, an
Yeah.
American
Yeah.
terrorist that sent bombs in maybe the 90s or so and killed Ted Kaczynski, his name was. I was sitting with my wife one night. We were sitting in bed watching Netflix, and we were watching a show on Ted Kaczynski. And we're sitting in there telling stories about his life. And they had his sister on. And his sister said, well, when he was 12, he got this infection, ended up in the hospital, and he was never the same after that. And I thought, oh my gosh. Start thinking about it and thinking, oh my gosh, could that be? I try not to, I always tell patients, I try not to, if I have a hammer, I try not to look at everything as a nail. So I don't, not everybody has pandas. Not every case of OCD is pandas. Not every case of anxiety is pandas. But I will say I see kids not just that have pandas, but I see kids with other stuff. I have kids that see kids with ADHD or depression or things. And what's amazing to me over these years is that by looking for other things, we see, oxidative stress or inflammation or other things that when you insert a little something there, sometimes you can see movement, and that's encouraging. So.
Yeah, fair and really rewarding. So, our developmental pediatrician, Dr. Simone LeBeouf, has a question. Can you speak a bit more about the symptom benefit you have sought with low dose naltrexone? She's been using it for chronic fatigue syndrome and encephalomyelitis, and primarily see a benefit for fatigue. So interested to hear about what other targets, I guess, amyloencephalomyelitis.
Yeah. So, it's been around, once again, not a new thing. It's been around, LDN's been around since the 80s and 90s. There's been a ton written about it. If you don't know about it, there's something called the LDN Research Institute. That might even be the URL, I don't remember. But the LDN Research Institute has tons of articles on low-dose naltrexone. There's a few in the information I'd sent you all, some references on LDN. And so LDN, in my mind, there's likely some anti-inflammatory stuff to it. I have not personally used it. We certainly see patients with chronic fatigue. I've not used it just for that indication. I tend to use it more in the situations where I'm thinking about immune dysregulation. So certainly long COVID or dysautonomia, those types of cases, and then infections and certainly PANS and PANDAS, those types of things I will use it for. So what it seems to do, the initial press around LDN, at least in the United States, was in rheumatologic diseases. So there are some articles on fibromyalgia. There are some articles on rheumatoid arthritis, Crohn's disease, also in kids. There are some behavioral articles in autistic children on behaviors for low dose naltrexone. So we've used it. I don't know what I really don't see kids under 5 typically. But I know other colleagues that have used it down to probably age 3 for different indications. So I tend to think of it with autoimmunity, also pain. So the other thing that LDN does is it releases endorphins. And so significant reduction in pain can be seen, especially in patients with rheumatic disease. There's actually, and it's been in production for several years, they're going to be, so you don't want to give low dose naltrexone to someone who's on narcotics because it'll precipitate withdrawal because it's an it's a narcotic reversal agent, a mu receptor blocker, I think as it is. And so, but they're coming out with a formulation, I think called Oxytrex maybe, that's going to have oxycodone and low dose naltrexone in it, ultra low dose naltrexone, like very low. And I think the idea is that it will give you maybe a longer duration of action of the narcotic, less potential for addiction, less breakthrough pain. So it's in process. Who knows if it'll live up to all that stuff, but that for fibromyalgia specifically, I think it helps in pain in that way. But I think we were just talking about this the other day in the office, and my physician assistant said to me, I feel like we use LDN for everything. And I said, maybe we do. So, but probably not my patients that come in for wellness or longevity or something. I probably wouldn't put them on LDN, but lots of stuff. Yeah, lots of things.
Thank you. I think this is the last of our questions here. So, thank you very much again for this really mind expanding presentation and your thorough answers for our questions. And I think many of us will go forth after this to, whether it's reading your book or exploring, this literature, because I think many of us are not even familiar or super familiar with like functional medicine, because that's a little bit, apart from what we do day to day. But I think you've given some indications of that. So, thank you.
My pleasure. My pleasure. Happy to be here.